The Compliance Perspectives podcast is sponsored by Case IQ, a global provider of whistleblowing case management and compliance solutions. Learn more at caseiq.com. Welcome to the Compliance Perspectives podcast. I'm Adam Turteltaub from the Society of Corporate Compliance and Ethics in Healthcare Compliance Association. Joining us today from Columbia, South Carolina is Ed White. Ed is a partner at the law firm Nelson Mullins, and today we're going to be talking about value-based care. First, Ed, overall, what's going on with the implementation of value-based care these days?
Well, thank you, Adam. And I'll just start with sort of a brief introduction. When we talk about value-based care, we're talking about payments for medical services that are dependent upon the quality and efficiency of the service provided. And that right now, CMS, the agency that administers the Medicare program, is driving the transition and change towards value-based payment systems. And you hear things like shared savings or episodic payments, and it's really to the degree you're increasing quality and lowering costs, you're creating new money in terms of shared savings, and CMS is sharing that with providers, so it can be incremental revenues to providers. In contrast, fee for service, the providers that's our historic payment system. They're paid separately, but it encourages or creates fragmented care with providers not collaborating, often having duplicative services and avoidable utilizations. And so the transition is designed to create more efficiency and higher quality. Historically, we've seen things like gain sharing arrangements, pay for performance, where you're paid extra based on performance metrics, and these organizations called accountable care organizations that came into existence in 2010. But all these programs and efforts are hampered by the regulatory requirements from CMS that apply to the Medicare program, principally the Stark Law and the Anti-Kickback Statute. Now, in 2020, the CMS, the agency that administers the Stark Law, and the OIG, which administers the Anti-Kickback Statute, collaborated and in tandem created their own regulations that address value-based care and encourage providers to transition towards those payments by relaxing these regulatory requirements. And previously, one of the main points here is previously participating in these programs was voluntary. In these government programs or even efforts in commercial payment programs were voluntary. But in 2026, we're going to have the first CMS sponsored program for Medicare providers that's going to be mandatory, and that's the TEAM program.
So let's focus on the Transforming Episode Accountability Model, or TEAM program. How does it fit?
Sure. The TEAM program is aimed, it's a mandatory program. There's 741 hospitals that were selected around the country that are required to participate in the program starting in 2026. And it's addressing 5 surgical procedures, and the hospital has to collaborate with providers that are providing services within 30 days of those hospital procedures. The program's for 5 years, and so if you're one of the selected hospitals, you're going to be in this, and the program's designed to require the hospitals to promote better care coordination among the providers that are providing services for 30 days after the surgical procedure, whether it's done in the hospital or in an outpatient facility. And these additional providers include, the specialists, the primary care physicians, outpatient therapy, skilled nursing facilities, home health agencies, labs, DME equipment, medication, and hospice. And the hospital is required to make sure the patient is connected with a primary care physician when they leave the hospital. Now, the program works. There's episodic based payments, there's a target price set for each one of these surgical procedures based upon historic regional costs where the hospital is located. But the program will reduce that target of historic costs by about 1% or 1.5% to encourage the savings, to create savings. And there's 3 tracks. The first track is upside only, meaning you can achieve or be paid shared savings if you come in below the target and you're increasing quality. The 2 other tracks involve upside and downside risk, which means the hospital could be paying money back to CMS. There's a moderate upside downside track, and there's a little more risk with more upside. And the providers in the hospitals have to start in 2026. And if they're not prepared, or if they don't want to yet go into a downside risk arrangement, they can defer that until 2027. But everybody's going to be in an upside downside risk in 2027. And the goals of the program are to encourage quicker recovery for patients, avoidable ER readmissions, to lower costs, and to provide seamless transition so there's more equitable outcomes among the services that CMS is paying for. But the main point here is the hospitals are at risk, and they have to start collaborating with other providers.
Given all that risk and the tight upcoming deadline, what should compliance teams be doing now to prepare for TEAM?
Well, I think in a very broad perspective, the hospitals and their compliance teams need to focus on getting good at partnering with these other providers. And that's going to be in a care coordination aspect and processes and protocols. Some projections by consultants are that 2/3 of the hospitals will lose money in this TEAM program, and I've seen presentations where consultants are demonstrating it doesn't take much to get upside down in one of these cases by as much as $20,000. So there's a high potential they could lose money, and I think the focus should be on not losing money first and then making money second. And it's going to require incentivizing the providers financially to really get on board and help move and drive down the cost. And historically, the Star Clause and the Anti-Kickback Statute have been problematic in being innovative in partnering with providers. And so that's going to be sort of the big message to compliance is you really got to move on getting providers motivated, and you got to be thinking about the Star Clause and the Anti-Kickback Statute as you go through that.
Let me follow up on that. What is going on with Stark and Anti-Kickback? There's obviously a lot of potential risk, but you mentioned there's also new regulations.
Okay, well, I want to start just briefly with the description of the Star Clause and the Anti-Kickback Statute. And basically, the Star Clause prohibits physicians, when they have a financial relationship with a hospital, from referring to the hospital for certain services, referred to as designated health services, unless an exception applies. And it's a rule, it's a regulatory regime of strict liability. If you're not an exception and you're in violation of law, there can be substantial penalties. The Anti-Kickback Statute is aimed, it's a little more amorphous and it's not as specific, but it's aimed at any sort of compensation being provided to parties that are referring to somebody who's billing Medicare, like a hospital. And the Anti-Kickback Statute doesn't work with exceptions, but it works with safe harbors. And just because you're not in a safe harbor doesn't mean you're violating the Anti-Kickback Statute. And both of these regulatory regimes have requirements that the payments to physicians have to be at fair market value. There's a lot of time and money spent in healthcare, particularly by hospitals, in documenting fair market value for every transaction with physicians. Payments under these regimes are not allowed to vary with the volume or value of the physician's referrals. Payments are not allowed also for referrals, making referrals. And these prohibitions, which I refer to as the classic rules, have hampered innovation and really acceleration of innovative partnerships that can really facilitate value-based care. And so in 2020, both of these agencies created these new regulations that are designed to facilitate the movement towards value-based payment systems. And they're both centered around this concept of a value-based enterprise. It's in the regulations for both. And to the extent the physician providers and other providers are participating, and think of it through participation agreements with a value-based enterprise, then you step into a new regulatory framework. And there's no fair market value requirement. There's no prohibition on payments varying with the volume of value referrals. And you're allowed in certain instances to subsidize the providers in care coordination. And that may be with the technology or consultants or care management workers, et cetera. That can be done under these new rules. The Stark Law, for the first time, allows payments for certain types of referrals and care coordination. And you can also, to the extent you've got providers participating in a value-based enterprise, they can be required to refer to one another. So you can steer the patient through the different providers, which historically has created a lot of concern and issues under both Stark and Anti-Kickback. And the bottom line is, with this new regulatory regime, you can create a low-risk environment or framework within to work on a value-based initiative like the TEAM program. And it truly allows you to more closely align providers in ways that you've not been able to do so in the past. So for compliance folks, this is a tool that can allow you to facilitate innovative arrangements to try to quickly move towards this mandatory program and adapting to the things you need to be able to do. Now, the program, and when you set up a value-based enterprise, you have to have certain purposes, and you have to have, document the activities and the protocols that you're going to be doing. You have to have a governing body that's responsible for setting up the protocols and activities and measuring progress towards that. And you're required to monitor and adjust the activities if they're not working. And I think the thought there is, these new rules, there's no required amount of progress you have to make, but you have to be making some progress if you're going to be in these relaxed regulatory standards. So it's documentation and monitoring and adjustment of the activities and programs that you're compensating providers on. But you really are in a world where you get to innovate and sort of create your own innovation center to drive towards these objectives. And it's very well suited for teams where hospitals are going to have to move quickly and be innovative in compensating providers to really help them come in below these targeted costs in this program. So these new regulatory regime is ideal for the TEAM program.
That's a lot of innovation and change, but we know in healthcare there's always yet more change coming. So what is coming next?
I think what we're hearing and sensing is that the movement towards value-based payment systems is going to continue to accelerate, and it's been moving along in recent years. It's been moving faster than it has in the past. It's our understanding the current administration and CMS leadership is very interested in programs that are increasing quality and lowering cost. And we think you're going to see more mandatory programs. And that's the big distinction, because until now, in 2026, providers could decide whether they wanted to participate or not in one of these programs. And this one's going to be mandatory, and the thought is that CMS is going to keep expanding not only this program, but add other programs as they adjust and determine what works and what doesn't work. And already there's another proposed mandatory program, aimed at specialists who, with certain types of heart and other heart failure and lower back pain in an ambulatory setting, and that's in a proposed form. So the message really is you've got to be focusing on getting good at working in collaborative care arrangements and working towards value-based care payments, because that is the future.
Well, it's clear that we're going to see a very different near-term future and even potentially long-term future for healthcare. Ed, thank you so much for sharing these insights with us today. I want to thank all of you for taking the time to listen. I'm Adam Turteltaub from SCCE and HCCA. I hope we're able to expand your compliance perspective.